Welcome. My name is MJ Schmidt, and I'm the Training and Outreach Coordinator for the Brain Injury Association of Pennsylvania. I'm excited to talk with you today about brain injury and the information and implications for criminal justice professionals. I hope that the presentation that I've prepared for you will be relevant to your practice and provide you with good foundational information about both brain injury and brain injury resources. So in this training, we're going to discuss brain injury, some basic facts, what it is, how often it happens, and to whom, and its effects. We'll discuss the intersection with justice-involved populations, touch on some resources, and hopefully provide you some implications and practical advice. This work is funded by a TBI partnership grant that's given to our Pennsylvania Department of Health, and we at the Brain Injury Association of Pennsylvania work in concert with them to deliver the content. To begin, let's just talk a little bit about how often brain injury happens or how big the problem is. On the screen, you're seeing a pyramid that comes to us. It's data from the Centers for Disease Control and Prevention. It's hospital surveillance data. And so you'll see that in a given year in the United States, we have 56,000 deaths, 288,000 hospitalizations, and more than 2 million emergency room visits for people who've had traumatic brain injuries. But then you'll notice there's a big red sloth across the bottom of the pyramid, meaning that we know that there are many, many more people that have traumatic brain injuries than we ever count. Why would that be? Well, in order to appear in this data, you not only have to go to a hospital, but you also have to get diagnosed with a brain injury. And so that's going to leave out many people. Take, for example, I have a son who plays a lot of sports that could get you a head injury. And let's say he is at ice hockey practice and he goes into the boards and hits his head and he's knocked unconscious, but for a very brief time. The coach calls me, I call my pediatrician, and he tells me, why don't you take him to urgent care? Or maybe, why don't you watch him overnight and then bring him into the doctor in the morning? Either way, even if my son goes on and has a complicated concussion, maybe one that has ongoing effects, he's never going to get counted in this data because he didn't report to a hospital. Similarly, you might have an older adult who takes a fall and breaks their hip, lands in the hospital, is in the hospital for some time, maybe even goes to a subacute rehab setting. And yet when they go home, they start to notice they're not taking their medications as fastidiously as they did before. They're tired all the time. They're easily overwhelmed. This might be a case where someone actually went to a hospital but didn't incur the diagnosis of brain injury. There are other people, though, who never report for medical care. It might be because they're underinsured, or they're not aware of the danger of a head injury, or it could be that they were involved in some kind of high-risk activity or were a victim of maybe an assault or some kind of intimate partner violence or child abuse, and they just didn't have the ability to report to the hospital. When we look at the research broadly, we know that those who are most likely to be counted in that bottom red slot are children, people who are living in poverty, people who are vulnerably housed, people of diagnoses, whether it's in mental health or substance misuse, and certainly justice-involved people. Acquired brain injury is the term that we use to describe all sorts of brain injuries, both those that come from a traumatic cause and a non-traumatic cause. An acquired brain injury is literally something that happens to a normally developed brain after a normal birth process. So it's not something that is congenital or hereditary or neurodegenerative. Instead, it's something that happens to a healthy brain, whether it's from an internal or external cause. Acquired brain injuries can happen from an internal cause or a non-traumatic cause, or a traumatic cause. And those are the traumatic brain injuries that you are probably familiar with. A traumatic brain injury, or a TBI, is something that comes from an external physical force. Now, of course, we all bang or jolt our heads on occasion. So where is that line? where do we cross into the term TBI? It really has to do with whether or not you experience an alteration in consciousness. Now, that can be being knocked out, and it often is, but it also can be that feeling of being dazed or confused for a moment. The kind of thing that we might see, in a football game where we see an NFL player get hit, get up, and sort of turn, not be sure which sideline to go for, even if it's a temporary effect. We would call that a suspected TBI. We measure severity of brain injury right at or around the time of the injury itself. And we measure it from mild to severe, again, based on that change in mental status. So a mild brain injury does include a concussion or a dazing, and it goes up to the point where someone is unconscious for 30 minutes. A severe brain injury is when someone has an extended period of unconsciousness, lasting 24 hours or greater. And a moderate brain injury falls right in that middle, from 30 minutes to 24 hours. The important thing to remember about severity of brain injury is that we're measuring it very early, and it doesn't tell us definitively how someone is going to be doing in their life. And so there are people who experience mild brain injuries who have life-altering changes. And then there are other people who have severe brain injuries who are really able to get back to the life that they once had. Again, from the Centers for Disease Control and Prevention, we're looking at the leading causes of traumatic brain injury. And you'll see that by far and away, falls are the primary cause of TBIs. Back when I began working in brain injury, which is more than 30 years ago, this diagram would look very different. At that point, traffic accidents, which are now at 14%, were the leading cause. But across time, we've had a couple of things shift. Cars have gotten lighter and safer, and our population is aging. And you're right if you were suspecting that those who are falling tend to be older adults. The second leading cause at 15% are your struck by and against injuries. This includes any time that the head is struck against something or something strikes the head. It would also include collision injuries that you might see on a sports field. Assaults are at 9%, and then there are 15% of people for whom the cause is something different or something that we don't know. As we think about traumatic brain injuries, it's important to understand our anatomy, particularly the anatomy of our skull. And so I'm going to show a video that can be very useful in understanding just which parts of our brain are most vulnerable to TBIs.
Okay, in order to understand what it is that happens to the brain when there's an injury involving force, such as what happens in a TBI, it's important to understand a little bit about the skull. So this is a replica of the skull. Inside the skull, it's different on the top compared to the bottom. The top is really round and smooth. There's really nothing sharp or bony to rub up against there. But on the base of the skull, the inside of the skull is very craggy and bony. And if you run your fingers around here, you could possibly even get a cut from how sharp and bony these orbitals are. These bony orbitals are formed by the back of the eye socket where your eye sits. The back of that is really sharp and bony. And so the brain rests in this cavity, and some very important parts of the brain rest right where those bony orbitals are. The underside of the frontal lobe, which is important for controlling behavior because of the rich connections to the limbic system, and the anterior, the front parts of the temporal lobe, which are very important in forming memories and being able to recall memory. These areas are very susceptible to damage because of the nature of the construction of the skull and the location of those important brain structures. So what happens in a traumatic brain injury, say what might happen in a car accident, where the car is moving along at 35 miles per hour and it suddenly comes to a stop because it hit something? is that your body keeps moving at 35 miles per hour. And what stops your body? Well, usually a seatbelt or an airbag will stop and prevent injury to the outside of your head. But when that happens, your brain continues moving at 35 miles per hour inside the skull and comes to a crashing halt on those bony orbitals. And besides the bruising and bleeding that can occur, the force of that injury and the rocking back and forth can cause what's called diffuse axonal injury, which is tearing of the very delicate microscopic neurons in the brain. And that can happen throughout the brain, in addition to that local injury that occurs right there where the temporal lobes meet the bony orbitals.
On this slide, we're seeing the interior of the brain, the neuronal network of communication within the brain. And this comes from an electron microscope slide. So we're seeing on the left a healthy brain and on the right an injured brain. And what we're noticing, obviously, is that the communication network on the left is much more robust than the one on the right. Messages can be sent within the brain sort of seamlessly without a lot of effort. Doesn't take a lot of time, it doesn't take a lot of energy. We could imagine that this individual would be able to sort of multitask, do two things at once without too much difficulty. On the right, we're seeing that an injured brain can in fact send messages, but that it's going to take a lot more time, a lot more energy. The individual on the right is working with what you might consider to be low Wi-Fi. And this is an effect we'll talk about later when we get into what happens after a brain injury. So we've been talking about traumatic brain injuries. Now let's pivot to those that come from internal causes or are non-traumatic brain injuries. What would cause a non-traumatic brain injury? One example might be a brain tumor. A brain tumor, even a benign one, is growing in space where it doesn't belong in our brains. It's taking up space, it's impinging on the structure, it's interfering with the function. And if you think about what we do to correct for a brain tumor, we often go in and remove it by surgery. And so we're going to sever connections within the brain. And then we might even follow up and treat it with toxins, poisons, whether we're radiating it or treating it with chemotherapy. Another common cause of brain injury would be an infection, like meningitis or encephalitis. Strokes, aneurysms, or any kind of bleeding within the brain would also be considered a brain injury. And I did allude to some toxic substances, such as radiation chemotherapy, but there are others that can impact the brain. Organic solvents, primarily pesticides, would be one example, as would be our heavy metals, lead or mercury. Alcohol and drug abuse can cause brain injury when it's used extensively across life. However, it's not a common cause. And I did skip one, you'll notice, anoxic and hypoxic injuries. And that's because I want to talk about that one a little bit more in depth. Anoxic and hypoxic injuries occur when the brain does not have sufficient fuel or oxygen to operate. And so this can come from something like a near drowning, where somebody is found in water, they're unconscious, they're pulled from water and resuscitated. Another example would be a near strangulation, whether someone has attempted to hang themselves or maybe has been the victim of any other form of asphyxiation. Another cause that we're very much interested at this point is the kind of hypoxia that comes after someone has survived a drug overdose. Non-fatal drug overdoses, particularly from opioid misuse, are a common cause of a non-traumatic brain injury. Opioids suppress our respiration and impact our central nervous system in a way that can cause something called toxic brain. And when someone is revived after an overdose with naloxone, it's not uncommon for them to have been without sufficient oxygen for a period of time. It only takes about 4 to 6 6 minutes for us to see significant cell death within the brain. And so this is a cause that we're very much paying attention to. I mentioned concussions earlier, and I do want to spend a little bit of time on it because it's such a common injury. A concussion occurs when an individual is dazed or experiences a very brief loss of consciousness after some kind of external event, falling off a bike, having a sports collision. And for most people, a concussion will heal fully within about 4 to 6 weeks. Concussions aren't visible on neuroimaging, and they're only diagnosed really by looking carefully at symptoms. However, while 90% of people who experience a concussion will heal fully, there are 10% of people for whom that is not true. There was a very interesting study done in Sweden by a researcher named Fizell. He and his team, who had access to national healthcare data, were able to look at 104,000 people who experienced a concussion before the age of 25 and their healthcare data for the next 30 years. What the researchers did is they compared how people's lives turned out, comparing them to their closest age-related sibling who hadn't had a concussion. And what did they find? They found that a single concussion may have lasting impact. In fact, they found that those who had concussions were statistically significantly more likely to have less education, to be or underemployed, to misuse substances, to have mental health challenges, to get in trouble with the law, and to die prematurely, often by suicide. And so the reason we mention this is that you might hear that someone has this remote history of having had a concussion and think that they'll be just fine. But for a significant group of people, that's simply not true. And to make matters even more complicated, we also know that brain injury begets brain injury. After an individual sustains a brain injury of any type, whether it's a concussion or a more severe injury, that individual will be 3 times more likely to get another injury. After the second injury, the risk for another injury is 8 times greater. We also know that multiple matters. The more brain injuries an individual sustains, the more likely it is that they will have life-altering effect. So what are the most common effects after a brain injury? On this slide, we're seeing a rather busy slide, but it's a nice simplified diagram of the lobes of our cerebral cortex. And we're going to talk a little bit about all of the lobes, but I want you to pay particular attention to the 2 lobes that Dr. Nagel alluded to as being most vulnerable to traumatic brain injury. And those are our frontal and temporal lobes. Our frontal lobe right there, it's kind of pretty blue. The front of the head is the seat of our executive functions. It's sort of the boss of us, if you will. It's the part of the brain that is last to develop into our mid to late 20s, a little earlier for girls than it is for boys. And it houses the things that a boss would do. So it's planning, organizing, evaluating, being able to anticipate consequences and inhibit behavior, being able to get started, being able to regulate one's emotions, including things like anger. It's also the place where we develop awareness of ourselves and how we're doing in the world. Very vulnerable lobe to brain injury. The temporal lobe, sort of over by the ear, if you will, is primarily responsible for memory and new learning. So kind of remembering what you did yesterday, what someone said to you, learning new things in school. It also has responsibility related to receptive language. On the top, sort of that maroon component of the brain, is the parietal lobe. And in our parietal lobe, we integrate sensory information and make sense of it. A parietal lobe would help you very much if you were carrying, for example, a very full tray in a cafeteria and you had to navigate between people and through doorways and sort of sense how full your cups were on top and whether or not you could tilt your tray a little bit. In the back, we see the occipital lobe, which is primarily responsible for processing visual information. You can imagine, in fact, the optic nerve running through to the eye in the front. So our eye serves as a camera, and the occipital lobe makes sense of the information it receives. We see our cerebellum, which is a pinkish red there in the back, which is responsible for gross and fine motor movement, coordination, and balance. And then finally, we see our brainstem. The brainstem is really a life and death function component of the brain. It tells our heart how fast to beat, our lungs how often to breathe. It helps us to regulate temperature. It helps with arousal, so whether one is in a coma or not. And it plays some roles with attention and sleep function. So as you can imagine, after looking at that slide on the brain, almost any kind of problem can follow a brain injury. And we're going to talk about them in categories. So let's talk about some physical changes or medical changes you might see. After a brain injury, people are more likely to have seizures, headaches, and pain. You see a lot of headaches, particularly after mild brain injuries. They might also lose their sense of smell and taste. We think about this in relation to COVID, but the olfactory bulb, which is responsible for senses of smell and taste, is in a very vulnerable spot, kind of right underneath our nose where you see a lot of those bones. So you'll often see that people will lose or have alterations there. People might struggle with their motor skills, with balance. They might have changes in their musculature, so they might become quite spastic or have tremors. They might have difficulty coordinating the muscles of their mouth in order to swallow or to speak articulately, and others might experience fatigue or weakness. There are a number of cognitive changes that happen after brain injury. Again, these primarily being related to that frontal and temporal lobe. And so individuals might struggle to think, to be able to choose, understand, or remember information. And we're going to touch on problems related to attention and concentration, information processing, memory, communication, and executive functioning. Attention is our ability to be in an environment, intuitively know what the most important thing to focus on would be, to sustain that focus on that item, and then potentially to divide our attention between that item and then be able to come reliably back. We need attention in order to learn something. And we certainly need attention when we're operating with any kind of complex skill in mind. After a brain injury, individuals will often struggle in any of these regards, and that will impact their ability to learn information moving forward. It can also be misperceived as an individual's willful disrespect or disregard of what someone is saying. As you will recall from the slide with the electron microscope representation, information processing can be slowed considerably as a result of brain injury. And so when an individual has decreased processing speed, they'll have trouble keeping up in real time with conversations or discussions or lessons perhaps at school or work. They won't be able to get things done in the time we would expect it to take, and they might not be able to get as much completed in a given time frame. When someone is experiencing slowed information processing, we can often look at them and misperceive that as they're not being interested in what we're saying, or maybe even that they're not being respectful. The other thing to note about slowed information processing is with all the effort it takes to take in information in real time, People with slowed processing will often find themselves cognitively fatigued. Cognitive fatigue is one of the most common effects we see after traumatic brain injury. In fact, we'll note that 70% of survivors of brain injury will complain of mental fatigue. It comes from all of the extra effort it takes for them to think after their brain has been injured. Individuals will report that they have to think through all kinds of common things that most of us just sort of do on automatic pilot. So people will complain of having to think through, for example, getting dressed. And because they're using so much more concentration and brain power throughout their day, it makes them get tired more easily, mentally tired. And so they'll have trouble sustaining their energy throughout the day. When someone is experiencing cognitive fatigue, they're much more likely also to have both headaches and irritability. Memory, which is associated with our temporal lobe, one of the lobes that Dr. Nagel spoke about as being very vulnerable to brain injury, is also very commonly affected after brain injury. Now, memory is not a unitary function. In fact, you'll see on the slide here, we've listed out 4 different types of memory, 3 of which are really commonly affected after brain injury. So our working memory, our ability to hold on to a piece of information while we're processing other information, is frequently disturbed after brain injury. So this happens to all of us. You get to the top of the stairs, you were coming up there to get something and you don't know what it was, and you have a failure of your working memory. But for people with brain injury, this happens way more often than it does to most. The ability to remember new information. So what you did yesterday, what you said to someone or they said to you, something that you're learning at work or school. This kind of new information is very difficult for people with brain injury. You'll see that the line is sort of drawn at the time that they had their injury. They'll be able to remember old information, things that happened before the injury. Those memories have been consolidated and people can access and retrieve them from their past. But after their brain injury, the ability to lay down memory and then pull it up when they need it has been disturbed. And then finally, prospective memory, sort of our ability to remember things into the future. Remember to do the things that we want to do or intend to do and have those memories pop up at the right time so that we can be effective. This is a very complicated skill involving both our temporal and frontal lobes, and it's often a problem for people with brain injury. So, having an appointment, knowing that you have that appointment at Tuesday at 2, but actually kind of pulling up that information early enough so that you actually are prepared, ready to go, and get there on time. These are the kinds of problems with memory that people with brain injury can have and that are likely to impact the work that you're doing. Individuals with brain injury will also struggle with their speech and language, their communication. So as a result of the brain injury itself, people might have trouble understanding or expressing themselves, whether that's verbally or in writing. You'll often see that individuals will struggle to understand what was said to them, to comprehend that language, or that they'll struggle to express their needs effectively or in an organized manner. Also, individuals with brain injury will struggle to understand and intuit nonverbal cues in the way that we would expect. As you can imagine, if someone is struggling to get the context of the communication because of maybe slowed information processing, cognitive fatigue, or specific speech and language failures, they're going to over-attend to nonverbal cues. And so you'll often see that people with brain injury are overly reliant on body language, tone of voice, cadence of speech, and they read a lot more into that in an individual that they're communicating with. So It's often emphasized in brain injury rehab that those of us who are working with individuals pay a lot of attention to our body language and the stance with which we take, the stance that we take with the individuals we serve. And so having that positive, neutral, I'm an ally kind of expression on your face and body language is critical. Because regardless of your words, that might be the primary message that someone is receiving. Next, we're going to talk about executive functions. Executive functions are housed in our frontal lobe, and they are, as the slide indicates, our boss. So this is the last lobe of our brain to develop, and it's responsible for very many of the adult-like functions that we're all familiar with, things that bosses do: planning, organizing, evaluating, regulating, making decisions, inhibiting. And so we're going to go through a number of the critical components of executive function and how they might be affected after brain injury. So let's start with initiation. Initiation is our ability to start doing something. It requires recognizing that something needs to be done, making a plan about how we're going to start doing it, and then putting that plan into action. So for example, if you want to get dressed, you first need to notice that you need to get dressed, and then choose what you want to wear, and then actually began gathering that clothing and then putting it on. After a brain injury, some individuals will really struggle to be able to complete a task that they have every intention of completing. So they often will have a goal, but they're never making any progress towards it. We'll think of them as being passive or unmotivated, maybe even lazy. Sometimes we'll even think it's because they're depressed, but this is actually a physical function within our brain that allows us to get started. The opposite of problems with initiation or getting started are problems with stopping. When we see individuals with brain injury who have impulsivity and disinhibition. And so these are individuals who aren't thinking ahead. They're not anticipating consequences or automatically employing rules. Individuals here are likely to say or do things without thinking. There's no filter that is deploying. They don't know when to stop. They're often not good with following rules or safety guidelines or directions. These individuals tend to dominate conversations, and they're often perceived as being rude or annoying. Planning and organization can also be affected by brain injury. Our brain is used to figure out how things fit together, how they're alike, and in what order they should go. Individuals with brain injury will often struggle with both planning and organization related to their space, as you see on this slide, or their time. And so they will struggle to figure out all of the steps that are part of a task and how they should put it in order, as well as to estimate how long it might take them to do those things. So as a result, individuals might be late or miss appointments. They might not remember to do the component parts of something that's going to be needed later in a task or into the future. Their spaces might be messy. So, this apartment that we're seeing is not well organized at all. You might see similar things with, for example, a student's backpack or somebody's binder or calendar. Also, when an individual has trouble sort of seeing how things fit together, they might give up very easily on complicated or multi-step tasks. Now, the intervention here is not really, for example, in this apartment, for me to run to Target and to buy a lot of containers and folders and things and give the person that stuff and say, get this organized. Instead, individuals with brain injury really need someone to figure out that structure for them and then to help them to maintain that structure. And so in thinking about how you might help an individual who's got these kinds of problems really kind of go back a step and think about how to set in place some structures that'll be useful for them, as it might be impossible for them to figure out how to sort of break down this big mess, for example, and kind of put it in an order that makes sense. Another problem that you might see with an individual with a brain injury is that with mental flexibility. So mental flexibility is our ability to see something from multiple angles, to see multiple solutions or options related to a problem. Individuals with brain injury might only see one way of moving forward, or they might get stuck very easily when there's a problem at hand. So that it's hard for them to think on the spot, and they may not be able to see something from someone else's point of view. And so the intervention here is really around helping someone to generate multiple solutions and evaluate each of those by predicting the consequences of actions or inaction in any of those steps. And it really requires that an individual have a trusted other that can help them move through problems as they emerge. Self-awareness and insight are very high-level thinking skills. Just thinking about how you're doing in your job, in a relationship, and evaluating your own behavior, that's pretty high-level thinking. And we see it commonly affected after brain injury. Individuals might not easily recognize their abilities or their limitations, or accurately perceive how they're performing or coming across after a brain injury. And as a result of that, it might appear as if they're denying their problems. We actually have a term for this in brain injury rehab. We call it anosognosia, and it's just a lack of self-knowledge or a lack of insight. And it's different than a psychological denial in that it's physically based. It's based on an injury to the part of the brain that helps us to develop an accurate reflection of ourselves. So individuals here might be difficult to engage in treatment because they don't recognize their need for it. They're blaming others for their problems. The intervention here is really to kind of help to join with that person and provide them with some feedback from a trusted other on how they're coming across and a path forward to do better. There are a number of emotional and behavioral issues which follow brain injury as well. Some of them are related to the neurochemical or physical changes within the brain, and others are related to the functional problems that follow a brain injury. So let's start with lability. Lability is a lack of emotional control or unpredictable mood swings. It might look like someone who is laughing out of proportion to the stimuli or joke, or crying sort of uncontrollably at seemingly small things. It's as if their barometer, their thermometer for emotions is just not where it should be. You may have seen commercials for pseudo-bulbar affect disorder, where people are laughing and crying uncontrollably, and this is what lability can look like. Alexithymia is another common problem. This is when an individual cannot recognize emotions in either themselves or other people. And so, an example might be someone comes home from work, they meet their partner at the door, the partner's been visibly crying, their face is pink and puffy and maybe tear-stained, and they just sort of start launching into how their day went that day. It's just not registering to them that the other person is sad. Similarly, an individual might not recognize an emotion in themselves, so they're getting angrier and angrier, and their self-perception is that they're cool as a cucumber. We've talked a little bit about irritability, which can follow cognitive fatigue, but it can be a condition that afflicts people with brain injury so that they just sort of are always a little bit on edge. We also talked about disinhibition, so that lack of filter or control, and this can be anger related or even sexual in nature. And it happens that individuals are sort of acting without thinking. And then finally, I want to mention anxiety and depression. So neurochemically, we can have changes after brain injury that sort of set the occasion for either of these conditions. However, there are also life circumstances which contribute. So if you can imagine not knowing what you said to this person that you're encountering or what they said to you, or not remembering what you did a week before, or what's coming next, it's a very anxiety-provoking way to live. Similarly, people with brain injury will have lost a lot, whether it's very concrete and they know they lost a job or relationships, or they just have this sense that they've lost their ability or their hopes, their aspirations. That can be very depressing. And so all of these kinds of mental health challenges can actually be facilitated by brain injury. And the real life consequences of the problems we've been talking about are those that you see on the screen. People with brain injury will have struggles in living on their own. They'll have problems in relationships. They're more likely to use or misuse substances. They'll have trouble at work, either getting jobs or keeping them. And as a result, they may experience financial hardships, and they're more likely to become justice involved. There's been a lot of research on the impact of brain injury on justice-involved populations over the past 15 years or so. We know now reliably through lots of research that more than half of inmates have a history of brain injury prior to their incarceration. We also know from the brain injury side that criminal behavior appears to increase after traumatic brain injury. This is also true of younger people, where we find the rate of traumatic brain injury is 3 to 8 times higher among juvenile offenders, with many of those youth having a history of losing consciousness and repeat injuries. And to make things more complicated, brain injuries in these populations and justice-involved people are often undiagnosed. And the slide sort of through visual pictures tells that story. These are often injuries that happened in high-risk activities or in sports or through violence. We also find a lot of brain injury in similar populations. Here on the screen, we're showing several that might be of interest and might overlap with those that you're working with. So people who are vulnerably housed have a much higher prevalence of brain injury than we would expect in the general population. Again, here we're seeing more than half have a history of brain injury, with 22.5% reporting moderate to severe brain injury. Children in foster care, an alarming study showing that 66% of those screened had a history of at least one TBI, with most of those caused by violence. People who have survived abuse, as you would expect, whether it's women, children, or people who have been involved with an abusive partner, report an awful lot of brain injury. Here we see 67% reporting at least one TBI, and 30% of those involving a loss of consciousness. So now that we've established that brain injury is common among justice-involved people, and that it impacts on people's ability to navigate their world, let's focus on its impact on success in programming. Obviously, the very problems that affect people with brain injury are likely to increase their likelihood of failing in treatment. So they are not always able, they don't come to the table with the capacity to use the treatment they are provided. And so for those of us who are working with individuals, we need to adapt the way that we implement treatment to facilitate their success.
I think it's always helpful to kind of slow down your speech and be a little more concrete. Less words, simple, there's that old phrase, keep it simple. Keeping it really simple, not a lot of steps in your directions, kind of a low tone of voice. Letting the person step aside with you so that maybe there's not so many distractions around them, and saying, hey, let's step over here and talk for a minute, so that they're not in the middle of a busy kitchen where they're unable to focus. Those sort of things are really helpful.
smaller and more frequent feedback is better because that helps people manage their behavior more successfully and helps keep things from going too far out of control.
If you want to be talked to at a level where you understand someone, you're going to talk slower, you're going to talk at a normal voice. Because if you're yelling at someone, you're going to expect yelling and anger back. And so I found that just the key for me is always just being slow, asking short questions, and that tends to work the best for me.
It sounds ridiculous in corrections, but be somewhat gentle. Try to be proactive. Talk to that person like any other person, and try to address issues as upfront and quickly as possible. Once things happen and things start to go downhill, they go downhill very, very quickly.
So while it seems really simple, some of the universal approaches for interactions are listed here on the slide. The first thing is to talk slowly. Again, kind of going back to that slowed information processing, problems with language. We want to slow things down. We want to make sure that our communications are simple, direct, and straightforward. We also want to make sure that we're watching our nonverbal communication. So keeping our voice low, making sure the cadence of our speech and our facial expression is neutral or positive, and when possible, pulling individuals aside or communicating with them in an environment where you have as little distraction as possible. You also want to make sure that the information that you're providing, whether it's specific directions about what's going to happen next or feedback, is given in small, more frequent chunks. And then critically, pairing that verbal communication, which is essentially air, with written information. So helping an individual to record step by step in small chunks what it is that they need to do next, what the critical information is, and making sure that's in an organized format or place so that they'll be easily able to refer back to it. And then finally, I think proactively, 3 great questions to ask when working with someone with a brain injury is, how do I help them to prepare for whatever the event is coming up? They need to go and speak to the school about their child. What are the questions that they have? Are they written out in a way and in a place that they can bring with them? They're going to a doctor's appointment, same kind of thing. How can you help them remember? So they're leaving either of those appointments. How do they know where to record the really good information that they need to do or the follow-up points? And then finally, and maybe most importantly, how can you help someone avoid difficult situations? So can you anticipate what interactions, what appointments coming up might be difficult for someone, and how can you either provide them the scaffolding to make it easier or to avoid it altogether? It's impossible to compile and discuss all of the kinds of strategies people with brain injury might benefit from in this short training. So here on this slide, I have a QR code that will link you to a fabulous compendium of strategies put together by colleagues of ours in Colorado. And so finally, I'd like to address resources. What are the resources? Where can you connect people who have a history of brain injury? In Pennsylvania, we are fortunate to have a number of resource streams that can fund brain injury rehabilitation. And we're showing some of them on the slides. On the very next slide, I'm going to show QR codes that will link you to each of those programs. And then we're going to talk about each of them individually. So here you're seeing the 4 QR codes that will link you to those various resources, all of which are housed on the Pennsylvania Department of Health's Traumatic Brain Injury page of their website. A resource that I want to address, not only because you might have some people that you're working with who are in school, but also many of you might be parents, is Brain Steps. Brain Steps is a school reentry program for individuals who've had brain injury. It is housed in the intermediate units across the state of Pennsylvania, and it allows for skilled team leaders to consult with schools to make sure that students are getting the accommodations that they need to make their education effective. In Pennsylvania, we're also fortunate to have a funding stream for both residential and community-based rehab called the Pennsylvania Head Injury Program. The Pennsylvania Head Injury Program provides for $100,000 or 1 year of services if an individual is qualified. Again, these services can be provided in someone's home or their community, or they can be residential. One of the QR codes links to a tip card about them. This program does delineate that the brain injury has to be traumatic. Again, kind of going back, meaning that it has to have come from an outside force. So a car accident, a fall, a fight, all of those would qualify. There are also some other qualifiers in terms of where the person was a resident at the time of the injury, and there are some income thresholds here, but it's a great program and it provides access to many, many people. We also have a program here in Pennsylvania called the Neuro Resource Facilitator Program. Essentially, this program provides access to a one-on-one case manager who has up to 20 hours to support an individual to identify, apply, and connect to appropriate resources. So again, we have a QR code for that. It's housed on the Pennsylvania Department of Health's website, or you can call this number. The Office of Vocational Rehabilitation is available to all individuals with disabilities, brain injury, and others. Here in Philadelphia, we have a county-based office right on Market Street. Individuals can call that number, or you could support them to do that, and they will support activities and services related to employment. So if an individual is looking for assistance in getting back to work or figuring out what it is that they would need and what kind of job would be best for them, this would be a great resource to connect them to. For those who have medical assistance, in Pennsylvania, we have Medicaid waivers that will provide funding for home and community-based services to qualified individuals. Again, this can be in a residential placement or in someone's own home. Individuals who would be qualified here must be required to determine a high level of care. In other words, they need to demonstrate enough problem areas that they would be at risk for institutionalization if they did not receive that care. And so these are managed, the eligibility requirements are managed through our area agencies on aging. The process to apply is a little bit cumbersome, but individuals who are interested can apply by calling the number on the screen, 1-877-550-4227, to get that application process started. And finally, if there's only one resource that you remember, this is the one that it should be. It is a number that you can call a brain injury resource line. It's not a crisis number, it's a voicemail, but you can call, kind of leave the information that you're looking for, and they will have that right person call you back to kind of direct you to next steps. This number is actually a national number, so if you have a family member in Florida, you could call this number and someone in Florida would call you back and help you get that process started. So that number is 1-800-444-6443. And so here is my contact information. I'm happy to help and to receive questions or emails that you might have in follow-up. And the QR code will link you to our website, which also has a lot of great information, including connections to support groups in the area and upcoming brain injury related events.